Good evening. Now we are coming to the Symposium 4, and that's just before the tea break. And I think we listened to one of the good critical analysis of our surgical training in Sri Lanka by Professor Aloka Pathirana. I think it's really a good eye-opener for all of us. And let's see what we are going to do with the women in surgery as well. So we have got 3 good speakers, and I don't think I had to introduce Judy Evans. She has been coming to Sri Lanka since I think 1910 or 1911, and she's a plastic surgeon. 2011 or 2000, regular. Sorry. Yeah, sorry. Sorry.
Okay.
So I think she's going to talk about the gender disparity in surgery, a global call to action. And in our Sri Lankan society, I think the female has a very big role because we treat mother as the role model in every family unit. And this is one of the countries, I think, probably the first female prime minister in the world. So you can see how people treat women as an equal partner, and there is no disparity from for the long time. So over to you, Judy.
Thank you so much. I would like to thank the whole of the committee who have organised this meeting and invited us to come, representing the Royal College of Surgeons of Edinburgh. Compassionate surgery as a theme. Most people have been thinking about compassion to patients, but it's terribly important as well that we are compassionate to our colleagues. And in this respect, I would subdivide compassion and say it's a combination of kindness, decency, and respect to the people around us. So in terms of compassionate surgery, Lucky has actually stolen my first line, which I was going to say how wonderful it is to be here talking on a topic like this in the country which gave us the first female Prime Minister. And unlike in the UK, your first Prime Minister was invited back after a period of time for a second term in office. We've never managed to do that in the UK. We seem to move our Prime Ministers on increasingly rapidly with the females. But there you go. Not everything, many people have mentioned, the UK is ahead of Sri Lanka. Well, that's not the case in everything. And certainly we're ahead of you in terms of litigation, and I would say to you, don't go there. But looking at the gender disparity in surgery, I want not to give you a lot of slides and figures, but to talk a little bit about my experiences through my career, to talk about where we are now, how things have changed, and to hand over very firmly to the future, because I think there is still a lot more to be done. So it's always been important to recognize that men and women are different. And that's not that one is better than the other. We need to accept that men and women are different. And sometimes discussions we've had in the last couple of days talking about alpha females, there are behaviors which are acceptable and accepted in the male, which are interpreted as being completely over the top, bossy, and aggressive in females. And one of the things that I've kept going through my time of dealing with some of the adversities I've had as a surgical trainee is always to keep a sense of humor. And you'd be amazed how much a simple smile can make things much better. So please keep smiling. Now, some examples of how much things have changed. My first day in theatre as a surgical junior, I walked into the theatre complex and I was faced with 2 doors, the changing rooms. One said doctors and the other said nurses. So what did I do? Well, I'm a doctor. I've never been a nurse. I went into the doctor's changing room, and there were urinals and all sorts of strange things around, including sets of scrubs which were green. So I went in, I put my things on, put on my green scrubs and went into theatre as very much the new girl. All the nurses said to me, "What are you doing wearing men's theatre wear?" So the next week I went in, and I went into the nurses' changing room, but when nobody was looking, I sneaked a few pieces of female underwear and hung them up in the men's changing room. They were old ones, and I just left them there. Within a week or two, the names on the doors had been changed to male and female. Great. So that's how I began my surgical training in England. Then I went, when I'd done some training, I went off for my FRCS examination. My examination wasn't exceptional for the standards of the day. The first question I was asked when I attended, 7 months pregnant, I was asked by a gentleman with a large pot belly, "What, madam, makes you think you can come here today looking like that?" Now, that sort of question would never be allowed these days, but it was something that I allowed to upset me at that time. And of course, I went on to fail and went along with the reputation of these examiners who would say, "Well, I've never failed a woman. I've never passed a woman. They're all awful." And at the end of my surgical training as a trainee, I went off for my consultant interview. My consultant interview was in the town where I had been the senior registrar for the previous 4 years. Nobody on the interview panel knew what happened to my children. My children were just treated normally. I had helped get them off to school, and I never allowed the children to stop me being a properly functioning junior doctor. So the first question in the interview was, "I know I shouldn't ask you this, but if we were to give you this job, how would you cope with childcare?" So of course, I just said, the same way as I've been doing it here in this town for the last 4 years, and you haven't noticed. I think if I was confident that I was going to get the job, I would have turned around and said, "No, you shouldn't be asking me this. And are you going to ask all the men the same question as well?" So it was very important to me as a young consultant to look at things that I could do in my own small way to change things. And at that stage, one could become an examiner 3 years after starting consultant practice. So I applied to the Edinburgh College, and 3 years later, I became the first surgical female examiner. And at that time, I was the only female on the exams committee, and because I call myself doctor rather than miss, which would have been equally embarrassing during my pregnancies, I call myself doctor, but co-examiners would come up to me at that stage and say, "Are you a pathologist? Oh, you must be an anaesthetist." They were surprised to find that I was a surgeon. So these are just little examples of things that are different now. Things have changed. And if we move on and look at entrance to medical school, in both Sri Lanka and the UK, we have approximately 65% of our medical students are female. For us, we will see more than 20% females in our examinations, in our surgical examinations. But I'm sad to hear that the figure for female members of this college is only 3.5%. So maybe there is something that should be done here to increase the number of female members. Last week, we were in Lahore, and I was expecting that there would be a huge gender disparity there. In one of our examination sessions, there were over 60% female candidates for the examination. So in those more junior positions, things are changing, and in some of them we would turn around and say, we've now got a much better exam, we've got a better system, and we are actually getting more females coming through, so the gender disparity at that level has, to a large extent, been certainly improved upon, if not answered completely. At the highest level within the surgical profession, you, of course, had your first female president in 2005. Other British colleges have had their female presidents. We in the Edinburgh College haven't done that quite yet, but we're well on the way with our first female vice president to achieving that very, very soon. So, looking at the gender disparity disappearing with the modern generation, we see that there are other problems coming along. You don't have sex discrimination if you're in a population where all the participants are of one sex. They're not going to have a bunch of men who are sexually discriminating against each other. They might be quite impossible to each other in lots of ways, but it won't be sexual discrimination. We're in an era where it's really important to speak out, and it's much more acceptable for us to mention problems which perhaps were not spoken of in polite or in public conversation in earlier times. Now, the Edinburgh College, along with the Royal Australasian College of Surgeons, have, of course, looked at the issues around bullying and undermining, which, while not completely gender-based, are very important aspects of our behaviour and how we should be treating each other with compassion. And I was very grateful to the College of Surgeons of Sri Lanka, which allowed me to present the Edinburgh College's Let's Remove It initiative at your meeting in Gaul. And I gave out lots of postcards. I hope you all heard of that. It's on our website if you want to look at it. And it's a very useful tool to think about how something can be perceived as bullying behaviour and therefore unacceptable. But in the last 3 or 4 years, the world has changed as well in terms of the voice of women. So we have women like Julia Gillard, the Prime Minister of Australia, and please go and look at her speech on YouTube. It's quite extraordinary how a Prime Minister could spend so much time talking about sexism and misogyny in the Parliament. Also, of course, the Australasian College talking about this at very much the same time. So all over the world, women are talking about what is important to them. And actually what we're seeing now is not so much a problem with sexual discrimination, but sexual harassment and bullying. And we've all heard of the Harvey Weinstein things, the Me Too campaign, and things like that spread all over the world in all sorts of different disciplines. And although we don't have a big named campaign for it within surgery, it's really important that we think about these sort of things. And the reason that I particularly wanted the male trainees to be here was to say it's really important for everybody to look around them and make sure that they are treating their colleagues with compassion. In the UK at the moment, there's a television campaign where you see a beautiful girl walking through a park. Some lads are playing football, and one of them turns around to the others and sort of says, "Oh, have you seen her?" And one of the other lads turns around and says, "That's an unacceptable behaviour these days." So it's up to the men to turn and tell their male colleagues what behaviour is acceptable. Because you can't have all the women being perceived as complaining about these things all the time. You have got to accept that there has to be a higher level of good behaviour from the men, but also within our own communities from the women. we need to behave to both genders with respect. And that's very, very important in all disciplines. So I'd like you to think about these sort of things. Go and look at our college website. Go and look at YouTube. And in the words of Jacinda Ardern, another of my female heroines, when she had her baby, she was only the second woman leader of a country to have a baby while in office. And she said, I don't mind the world knowing that I've just had a baby, but I want to get to the point where it's no longer newsworthy. So, ladies and gentlemen, my hosts, thank you so much again for inviting me to talk. I think my generation have cracked the glass ceiling. We may even have got a few bits falling off it, but it's over to the next generation to build on that and make sure that one of the next times that I'm invited back here to what has become my second surgical home, we'll hear that there is equality for men and women across the world as surgeons. Thank you.
Thank you very much, Judy. And our next speaker is Dr. Udayangani Samarakkody. She's a consultant pediatric surgeon from New Zealand, and she's going to talk about being a woman and surgeon from brilliance to excellence. Yeah, over to you.
Thank you very
Udayangani.
much, Chairpersons. Thank you, College of Surgeons of Sri Lanka, for giving me the opportunity to be presenting today. I have a problem with this slide. If you can please adjust it. It's always a pleasure to come to my paradise. So when I was given this topic of being a woman and a surgeon from burnout to brilliance, I requested to change it to brilliance to excellence rather than burnout to brilliance, and I had a reason for that, because we are indeed not talking about burnout in women, we are talking about women as surgeons. Just as we discussed earlier, this is a famous picture that appears in the social media, the multiple tasks that Dr. Mums have to do, and I myself was not spared from that. I had my surgical training in late 80s and 90s, and performing multiple roles as a wife, as a mother, as a looking after parents, and running a house, and multiple other tasks. Building a house, trying to collect money for a car, all that. And then you end up having to go overseas for training. And as you can see, multiple trips back and forth to UK and to England, to Australia and back to Sri Lanka. And then trying to get through 3 training programs and examinations. Did I cope with my training? Did I flourish in my training? Outwardly, I probably would have looked like I'm in full control, coming out from the medical school with flying colors, and, you think the world is your oyster. But I never thought that I was actually flourishing. I was barely coping. Then, of course, after a short stint as a consultant in Sri Lanka, I moved to this beautiful country and made it home. But of course, I had many, many trips back and forth to my paradise. During my early career, I did a master's degree, and I chose surgical training because of my interest about my coping abilities as a surgical trainee. And in this master's dissertation, this is the very final conclusion, and it depicts the trainee in the middle with many aspects that the trainee him or herself has to look after: lifestyle, stress management, organizing the support network, and organizing their own work and training structure to suit them. And institutions, the society, and your own personal responsibility play a major role in the scoping of their training. However, subsequently, on that background, I have thought about, rather than looking at how people cope, why don't we look at how they actually flourish? For example, what are the enabling factors that enable someone to flourish in their training? Being a woman or a man, it doesn't matter. There is no gender difference here. Women just have to do more work because they have another full-time job when they go home. There is a lot of literature on burnout and physician attrition, and that is what I would call deficiency model. Whereas there is another aspect where the trainees engage, build resilience, and achieve excellence, and that is the strengths model. How does clinical learning environment help them? Like Professor Aloka Pathirana mentioned earlier, the clinical learning environment support systems provided by the family, from the society, and by the training faculty would make a huge difference to somebody's well-being during training. And do we enjoy our surgical socialization and team culture? I certainly did during my training and today too. Engaging in your training requires a high levels of vigor, dedication, and absorption to and in their work. And this is way beyond material and financial gains. You all are surgeons or surgical trainees, and I know for sure, just like how I did, we are not looking for material and financial gains when we are training. We have a meaning and a purpose in our work, and this is congruent with domains of flourishing that was described by Aristotle thousands of years ago, called eudaimonia, good life through flourishing to realize the potential of the mind and self for personal and intellectual excellence. We engage in strenuous pursuit of these activities to achieve excellence, be it surgical training or surgical operation. This is very different to what's called hedonia, where you do something for pleasure, like going on a roller coaster and enjoying the adrenaline rush. Some of the operations that we, or most of the time, when we perform surgery, we are fully engaged in that activity, and it challenges our skills, which is balanced with the challenges that are put to us by the patient's necessity. Here, we have clear goals, we lose track of time, forget our own problems, and feel wholly immersed in the activity. And we reach the peak of involvement, feeling the intense enjoyment and creativity. That resonates with flourishing. And a lot of you would know Maslow's levels of needs. And B cognition is one of the other aspects that Maslow has described, where one is very focused on a single object, and it could be a work of art, it could be playing a musical instrument, it could be falling in love with somebody. You forget yourself, you are wholly mentally, physically, intellectually immersed in that event, and the rest of the universe disappears on you, and that resonates with flourishing. So, coming to the Maslow's hierarchy of needs, we all know that we all need food, water, warmth, and rest. That is the lowest level of physiological needs. But we in surgery are at the top of Maslow's hierarchy of needs and beyond. Self-actualization is the highest need, that highest hierarchy that Maslow described, but compassionate surgery, pro-sociality, altruism, where we are thinking about the other person rather than oneself, be it staying back for an operation that needs to be done for a child, be it that you're missing your son's birthday party, but there is a patient who needs to be looked after, and you might actually give up on some of the pleasures of life for the sake of pro-sociality. Surgery is a practice, and it's not a job. It has multidimensional vocation. It is a multidimensional vocation, which involves intellectual, moral, ethical, and skillful delivery of an act. It requires high degree of technical skill, and it involves complexity, need to achieve excellence, integration of means and ends, and continuous development. And we need to have a disposition that is worthy of a surgeon, such as zest, hope, love of learning, and personal growth. And I talked about pro-sociality and altruism already. So workplace learning, whether you are a female or male, involves an apprentice model, and there is supervision and mentorship, and a conducive clinical environment needs to be provided for good learning, and curriculum design should suit the training and the trainee more than the trainer, and challenging work given to the trainee with stress in small doses, and obviously work-based assessments and examinations. So how do surgical trainees engage professionally and flourish with implications for excellence? And this applies to women more, although it applies to both genders, it applies to females because of the extra bit of work that we as females have to do. So I looked up, with the intention of performing a scoping review, I looked up keywords and mesh terms and looked at the strengths model in English language only during years 2000 to 2021. I excluded surgeons. I only took surgical trainees because I was more interested in my training and how people cope during training rather than myself as a surgeon when I had better control of my life. So I ended up sourcing 33 reading text articles and spent hours and hours, days actually, reading through those articles and finding a theme. We are all qualitative researchers. We are not, we are all quantitative researchers, and qualitative research is hard because we have not grown up with it. So I found this part of the research quite challenging. So to give a Prisma chart of the Prisma chart with extension to scope in review, I have found 186 articles at the beginning, but I pulled it down to 67 in the end. And then once I excluded all the other factors that I discussed earlier, I boiled it down to 33 cases, 33 publications. And thematic analysis revealed that excellence, and I'm not talking about brilliance here, I'm talking about excellence, involves academic prowess, and that is what I would call brilliance. So we all finish our medical school and possibly finish our training also with academic prowess, which is brilliance. But during our training, we need to have a very satisfactory journey. Our well-being is quite important. There are a lot of intrinsic factors that may be not present at the beginning, or you might be having that inherently. Things like resilience, job crafting, emotional intelligence, etc. And support systems, which is so valuable for females. Support system where you have your parents, childcare, breastfeeding ability, able to take some maternity leave, etc. And of course, friends play a huge part in your life. So, flourishing is equivalent to excellence in my mind, and I discussed these factors. And I would like to akin it to the Maori health model that is very well guarded in New Zealand, where there is taha tinana, physical health, taha vairua, spiritual health, taha whanau, family health, taha hinennoro, the society's health or the society's involvement. With that, I would like to finish my talk, and I would like to thank you all again for listening.
Thank you very much, Dr. Samarakkody, for that interesting talk. Our next speaker is Dr. Minoli Joseph. She is the consultant oncosurgeon from National Hospital Kandy. She'll be speaking on challenges faced by female surgeons in Sri Lanka. Let's face the facts and myths. Over to you, Dr. Minoli.
So let's look at the history of women in surgery in Sri Lanka. So Dr. Mary Ratnayaka was the first female medical student in Sri Lanka. It is also stated that she did a fellowship at University of Edinburgh, and after that she worked as the chief surgeon at Lady Ridgeway Hospital in Colombo. Also in 1943, she became the first female president of the Ceylon Medical Association, as it was known then. So we had an excellent head start, a promising beginning indeed. Even before independence, we had a female president heading the largest association of doctors in the country. So where are we now? According to the statistics from University Grant Commission, there is a female preponderance of medical undergraduates in Sri Lanka. When I started out in year 2000, my batch had about 50% of women, and it was unprecedented at that time. And 20 years later, as you can see, it has risen up to 65%. There is robust data showing that females actually do better than males in their undergraduate medical careers. According to the study published in Ceylon Medical Journal in year 2000, female medical students are less likely to fail undergraduate medical exams and are more likely to obtain honors than their male counterparts. I'm sure most of you have seen the recent video clip, the convocation of Faculty of Medical Sciences of the University of Sri Jayawardenepura, where all the medals were awarded to female students. But what happens when it comes to postgraduate exams? The number of women pursuing postgraduate studies is significantly lower. Actually, histopathology and hematology have the highest percentage of female consultants, which is around 85%. Surprisingly, ophthalmology and anesthesiology, where they have a fairly busy resident period and night on calls, also have a significant proportion of female consultants. What about general surgery and its subspecialties? It's at a dismal 5%, not even double digits. After the promising start by Dr. Mary Ratnayaka in 1930s, where are we today? Dr. Indrani Amarasinghe, consultant surgeon, became the first and only female president so far of the College of Surgeons of Sri Lanka. She was also the only female member of the council for a long period of time. Why is there a dearth of females in surgery in Sri Lanka? So let's look at the surgical training. As Professor Alok Patirana said in his talk, Postgraduate Institute of Medicine was established in 1980. And since then, we have a very robust surgical training program where entry is purely by a competitive exam. Even after all those efforts, there is a significantly lower number of females attempting the entry surgical exam. Although the numbers entering the program are low, most of the female trainees complete their training. There is no overt discrimination in either the entry or exit exams, as they are marked according to a strict marking scheme. So let's look at some common myths. Surgery is commonly presented as a man's job. From their undergraduate days, females are often subtly dissuaded from surgery. It is often said that females prefer a career and a training with less intense on-calls commitments also. Surgeons are said to have a little time for their families, and female surgeons are less likely to be recognized for their skills and achievements due to stereotyping. But actually, these have no rational basis at all. And in the words of Justice Ruth Bader Ginsburg, who was the first Jewish female and second female Supreme Court judge of the United States, there is an element of unconscious bias against females in surgery, even though there is no overt discrimination in this day and era. Also, those are certainly very much open to us at the moment. So the main problems we have at the moment in Sri Lanka is a dearth of a role model, with fewer female surgeons as mentors, and it perpetuates a vicious cycle which must be broken down so that critical mass of female surgeons are reached. A conscious effort must be made to promote surgery to females in their undergraduate careers. Work-life balance is also a common problem, but it's a myth, as the other surgical specialties also will face the same problems with their families. But however, in Sri Lankan setup, we have a lot of positive factors that are unique to our health system, unlike the United Kingdom or USA. So we all are paid the equal amount in our health system. So we don't have a gender pay gap. Also, selection of postgraduate specialties is based purely on merit through a performance at examinations, and there are no residency interviews as in other countries. Finally, appointments and transfers. Those are based purely on seniority, and that means there is no room for overt gender discrimination in Sri Lanka. So the College of Surgeons will shortly inaugurate the Women in Surgery Forum with a view of expanding opportunities for women to pursue a career in surgical specialties with these objectives in mind. In summary, the female preponderance in medical graduates makes it imperative that real and perceived barriers that deter females from entering a career in surgery needs to be addressed as a matter of priority. When conscious and unconscious gender bias disappears, it will make it easier for us who wants to be surgeons to make a better choice in our surgical fields. As stated by Malala Yousafzai, we cannot succeed as a specialty when half of us are held back. Finally, I would like to end by repeating the often quoted phrase that a good surgeons need a lion's heart, an eagle's eyes, and lady's fingers. Let's hope that there will be more ladies' fingers entering our specialty as we journey together towards a common goal for more compassionate surgery. Thank you.
Thank you, Minoli, for that eye-opening speech. Next, I would invite Dr. Satish Gunasinghe, President of the College of Surgeons of Sri Lanka, to launch the Women in Surgery Forum.
Words before we start the forum. I think there is no gender difference in surgery. And when you look at the 1970s, in US medical schools, only 6% were medical students. And now we have over 60%, 70% medical students being female. And on a personal note, I must say, Dr. Samarakkody, I worked as a registrar under her 27 years ago. She was pregnant, almost about to deliver with her daughter. Even at 1 in the night, I was a registrar. She used to come with her young son, and he was put to sleep in the surgeon's room, and she operated on tracheoesophageal fistulas even at 1:30 in the night, and I was the registrar. I can still remember the dedication she displayed as registrars, as a consultant pediatric surgeon. So she practices what she tells, and I've seen to my own eyes. And female surgeons are surgeons. We don't have a gender divide. But unfortunately, everywhere in the world, political rights are given to females, but when it comes to civil and social rights, they are abridged. When it comes to rape, abortion, and different aspects, we see that they are abridged. We thought with Roe versus Wade, things were liberal in the United States, but now once again with the conservative bench, it's going backwards once again. Famous Jackson case, which was decided. But with the gender shifts that is happening now, I'm sure men will form a men's surgical forum in the future with the preponderance of female surgeons. We are getting more medical graduates. I'm sure the boys here will ask the council, may we form a male surgeons forum? I'll be a very feeble old guy, but I'll be coming for that meeting as well. But this is not only about female rights as surgeons. This is to understand the female's vital role in the family. We have to recognize they have children. They have to nurture, bring up children. So we have to be facilitatory as well when they become trainees within, margin for them to have, run a family, and while at the same time to be surgeons. So macho surgeons are gone now. All compassionate surgeons who will be tolerant and respect diversity and the necessary needs, and we had to be humane surgeons. So with the permission of the council, we decided we have two brave, assertive council members, Minoli, Bandhusena, and Sandhini Vijayaratne. They are very assertive, and they have hearts of lions. That's what a surgeon needs. And congratulations, Minoli and Sandhini, for your hard work. And we launched the Female Surgeons Forum. But there are some opposing views. That's the society. But we have to do what is right. So I'm going to do what is right for the college to set up the Female Surgeons Forum. And they will never take umbrage under the Female Surgical Forum and shirk work. Both of them are hard-working surgeons, and I'm sure they'll work very hard while looking after their families really well. And I wish to invite Minoli up to the stage and Sandhini, and we are hereby launching the Female Surgeons Forum. That will be a formal subcommittee in our college. And every month we'll be reviewing your work, and you'll be reporting back, and your forum will have male facilitators as well. Thank you very much, Minoli. And thanks. And on the same note, I wish to invite Judy over to the stage, because you are leaving us early tomorrow. You will not be here for our activities. Thank you so much, Ms. Judy Evans. And Madam, may I call you Madam because I was your registrar. Madam also on stage. I'm very happy. I'm so happy to be her registrar. Aloka was one of her registrars as well, and we had to work very hard with her. Virtually we lived in the LRH, but it was a pleasure to work with you, Madam. So with all of them, we launched this forum. And as Judy, you are leaving us today, we have a small memento from our college, appreciating your inputs.